chat box. This webinar is being recorded and will be available through the OPS website's education page. Our moderator for today's forum is Dr. Bruce Goldberg. He is a professor at the OHSU Portland State School of Public Health and a nationally recognized consultant on health policy and the organization and delivery of health services. Dr. Goldberg served 2 Oregon governors as the director of the Oregon Office for Health Policy, director of the Oregon Department of Human Services, and then was the founding director of the Oregon Health Authority. He currently chairs the Oregon Joint Task Force for Universal Health Care. Our panelists today, in order of speaking, are Dr. Samuel Metz, who is a member of the state's Universal Health Care Task Force and was part of past legislative work groups on universal access to health care. Dr. Metz is vice president of the Oregon Physicians for a National Health Program. His opinion pieces have been published in the New York Times and many Oregon publications, and he's been featured on national public radio and local broadcast media. Tracy Davis is a partner and employee benefits consultant at Aldrich Services based in Salem. She works with employers to implement innovative solutions for funding and cost containment with an eye on the future direction of healthcare. Tracy helps her clients address their goals and strategic objectives related to the complex and changing healthcare landscape. Dr. Glenn Rodriguez is a retired family physician and physician executive with long-standing engagement in public health policy in Oregon, his special interests are in family medicine. I'm going to start that sentence over again. His special interests are in family medicine education, elder health care, and efforts to strengthen the primary care system in Oregon. He is a member of the Oregon Primary Care Payment Reform Collaborative, Oregon Patient-Centered Medical Home Standards Advisory Committee, and the House Health Committee Work Group on Universal to Primary Care Access. Dr. Rodriguez also serves on the boards of the Oregon Medical Association and Care Oregon. Dr. Lisa Reynolds is a pediatrician, an OPS member, and has been in private practice at the Children's Clinic in Portland for 25 years. She has been a strong advocate on gun violence prevention and child health, and is the mom to 2 sons in college. As of this month, Dr. Reynolds is a representative-elect to the Oregon legislature, taking office in January of 2021. I'm so pleased to have these panelists and Dr. Goldberg moderating this forum today. Dr. Goldberg, take it away.
Thank you very much. Good morning, everybody. What a great morning. Looking forward to a great panel. A couple of introductory comments. You know, it's really interesting. Oregonians have several times in our history asserted that all of us in this state should have basic health care. In fact, over 30 years ago, that was one of the tenets of the Oregon Health Plan. And although that was 30 years ago, we still call our Medicaid program the Oregon Health Plan. And with that, I think has come the hanging on, the fact that we're continuing to hang on to a value that everyone in our state should have basic health care. We haven't gotten there yet, but we keep trying. Right now, we find ourselves in the midst of really a terrible healthcare crisis and a pandemic. And that pandemic has, I think, magnified many of the problems with our current healthcare system. We saw millions of people in our country lose healthcare coverage overnight because it was tied to employment. We've seen hospitals and doctors going bankrupt because of our payment systems for care. We've seen people being confused about whether something's covered in the midst of the worst public health crisis in a century. The pandemic has really shone a light on the inherent racism within our system and the health disparities that exist and our inability to have an equal and just healthcare system. And the fact that we don't have a public health infrastructure that we can count on in a time of need. So a lot of people have said this. It's a quote attributable to many, but a crisis is a terrible thing to waste. And we'll see what we do with this crisis. In the context of this crisis comes fortuitously, I believe, Senate Bill 770, which is the state's task force on universal health care. Sam is a member, I'm a member. And it's a 20-member joint task force with 4 legislators and 13 members appointed by the governor. And our task is to create a single-payer healthcare financing system for Oregon, one that will equitably and universally include all residents in the plan, and that will preserve the coverage of healthcare services that are currently required by Medicare, Medicaid, the CHIP program, et cetera. A lot of considerations in doing that. I think we'll get to some of them this morning, and each of them have trade-offs. You know, there's the issue of benefits. What benefits do we provide? The more benefits we provide, the more this costs us. The less benefits we provide, the less the less beneficial a plan is. Are we going to have cost sharing? How and how much do we pay healthcare providers? What's the role of insurance companies? How do you finance this? What's the most equitable way to finance a universal healthcare system? How do you manage and govern it? And then how do we deal with the number of regulatory issues, which I'm sure we'll mention today? You know, issues of ERISA. So it's fantastic. We have Tracy with us this morning as a employer benefit specialist. Waivers. We have to deal with a national Medicare system. And I think finally, to me, one of the biggest issues is no matter what happens, how do you gain support for something in a time where healthcare has become such a polarized issue? Not just universal healthcare, but where wearing a mask or washing your hands suddenly becomes a political statement. So that's the context with which we sort of enter into this morning's conversation. And I couldn't think of 4 greater perspectives to have than the ones we have with us. What we're going to do is have each of our panelists talk for about 7 to 10 minutes. And in between each of that, I'm going to give an opportunity for panelists to ask the other panelists questions if they so desire. And then once we get through the 4 presentations, we're going to open it up to the audience for Q&A. Please put your questions in the Q&A spot. And with that, we are going to start with Dr. Sam Metz. Sam. And Sam, you're on mute.
Thank you very much, Bruce. I'm still trying to get comfortable with the 21st century. What COVID has given me, by the way, is what my wife says is a hairdo that matches my personality. It doesn't really follow directions and is a little wild around the edges. What I hope to do is cover some of the terminology that will make our discussion easier. The purpose of healthcare reform is the simultaneous achievement of 3 goals. The first one is access. As the head of family, I want to know that when I wake up tomorrow, no matter how hired, fired, retired, or expired I become, my family will get the care they need when they need it, no matter what our credit rating is. Second, I want my costs to go down. I pay for healthcare in a variety of ways, through taxes, premiums, out-of-pocket payments. That sum, no matter what the label is, has to go down. And finally, I want better outcomes. I don't want to have to tell a pregnant member of my family that there are 59 other countries where she and her baby have a better chance of surviving the pregnancy. This is sometimes known as better care to more people for less money. Achieving any two of these goals is easy if you sacrifice the third. Getting them all simultaneously is hard. That's why William Keswick called this the iron triangle. When we look at how we get money from patients, also known as taxpayers, to providers, we can think of it as a huge pipeline that goes from one side to the other. One question is, how does money get into the pipeline? Is it premiums? Is it taxes? Is it out-of-pocket payments? This is called financing. Around the world, there are two basic kinds of national financing of healthcare. One is called universal care, and the other is called chaos. The United States is the only nation that practices chaos. For other countries, everything that goes into the pipeline is either through an organized system of private insurance payments or through taxes. One is called multi-payer, the other is called single payer. How we distribute the money to providers on the outside depends upon whether the providers are public or private. Most nations use a mix of private and public providers. In the hypothetical case where we fund all of healthcare with taxes as a single payer, and we pay for all providers as government employees, we call that socialized medicine. Not only is that rare, we only know of 2 instances in the entire world of socialized medicine. One is in Cuba, the other is the American VA. There are no proposals, major serious proposals in the US for healthcare reform that create socialized medicine. Many of them create single payer, still preserving the mix of private and public providers. As far as we know, our experience with hundreds of years of healthcare, the only known method of providing better care to more people for less money, that is landing in the sweet spot of the iron triangle, is universal care. Universal care is more than just a verse in a Peter, Paul, and Mary song. Universal care has 3 components. One is everyone is mandated to participate in a prepaid healthcare plan, be that through premiums or taxes. No one can be excluded, no one can opt out. Every healthcare policy, public or private, provides the same set of comprehensive benefits. Comprehensive does not mean unlimited. It means treatable conditions receive a treatment. In every country, you can buy more insurance with more money and get more benefits, but you can't pay less and get fewer benefits. And finally, there's one network. Any patient can see any provider, and provider payment reflects the value of the service, not the insurance company of the patient. Every nation has corrupted this series of 3, but not to make their systems more efficient, but for political expediency. Any compromise reduces efficiency. The United States is the only country that has done away with all 3 of these characteristics, and consequently, we have the least efficient healthcare system in the world. We pay more money for less value than anywhere else. Hence the need for universal healthcare. Lastly, I'd like to talk about universal healthcare and provider payment. Universal healthcare affects provider payment, especially primary care provider payment, in 2 ways, whether it's single payer or not. First, any universal care plan increases the demand for primary care. That's pretty intuitive. to invite more people to go into primary care, we'll pay them more. Where's that money going to come from? If we're not going to pay providers more, well, it's going to come from highly paid medical specialists like anesthesiologists like me. So I can expect that under a universal care plan. Second, if all of my reimbursement per hour or per service now reverts to the mean, my payment per service will be less than what private insurance pays me now, more than what Medicare pays me, a lot more than what Medicaid would pay me, and a whole lot more than having my claim denied. So you can look at your medical practice and find out which quadrant are you in and how will universal care affect you. If you are a highly paid medical specialist and all of your current payers are private, universal care is going to bring your gross income down. If you're a primary care provider in the other quadrant, and most of your payers are government pay or self-pay, you can expect your income, gross income, to go up. And if you're in one of the other quadrants, you have to do the calculus yourself. There are advantages to universal care plans that all providers enjoy. One is every patient becomes a paying patient. And you can take your your paying patients anywhere in the state. Doesn't matter where you practice, you will get paid the same, you will get paid promptly. And you don't have to worry about providing healthcare benefits to your employees. For one thing, you'll need fewer employees because your paperwork has just gone down. The number of billable events has gone down. And you know your family will enjoy access to healthcare even if you stop being a highly paid medical specialist. Not only will your family enjoy access to healthcare, so will your extended family, your friends, your community, and the rest of the state. So these are some terms that we'll be talking about. We'll be talking about the iron triangle of better care to more people for less money. Any policy that doesn't apply all three of these simultaneously is not healthcare reform. It's rearranging the deck chairs on the Titanic. We know that universal care can answer the iron triangle, a plan that includes everyone, single insurance policy, a single network, and that the effect on primary care physicians really depends upon where you're starting. But regardless, you can expect your cost of living to be reduced, your ease of clinical care to improve, and the healthcare security of your own family to improve. Thank you very much.
Thanks, Sam. That was great. So I'm going to see if Tracy, Lisa, or Glenn have a question for Sam.
Sam, at the onset, you mentioned the objective of healthcare reform was to improve access, costs, and outcomes. On behalf of employers who have struggled with the maze of the Affordable Care Act, how has, or maybe better yet, how should healthcare reform address each of those three things?
It's a great question, because when I take off my hat that says head of family and I put it on as business owner, I come up with a different set of criteria. I have some familiarity with this from years ago, soliciting business contributions to what became the RAND study. So this is an informal description of the list that a business owner might ask of a healthcare system. First, get the business out of healthcare benefit management. I heard one business owner say, I know a lot about sheetrock. I don't know anything about healthcare. Second, keep my employees healthy and productive, whether they're full-time or part-time. If they call out sick, that's lost productivity. Third, I know you're coming after me for money. Just make sure you don't take more money from me than you do from my competitors. Next, I know you're going to be offering healthcare benefits. The benefits to my employees have got to be at least as good as benefits that go to other employees. And lastly, whatever sort of screwball system you come up with, it's got to be simple enough that my future healthcare costs are predictable and stable. My guess is a universal healthcare system answers at least most of these requirements and certainly does much better than almost any of the non-universal care plans that have been proposed. Universal healthcare is not perfect for employers. It's just a lot better than what we see now.
Great, thanks. Thanks, Sam. And I would just want to remind everyone in the audience, keep your questions coming in. I'm monitoring them. We're going to get to those after the panelist presentations. Some great questions coming in. And so while we're on employers, I think it would be a perfect time to switch over to Tracy for her comments.
Thanks, Dr. Goldberg. So as an employee benefit consultant, we represent employers in obtaining their healthcare for their employees. And Dr. Metz, you hit it perfectly. Employers are put in the position of providing healthcare to their employees, either as a requirement, as a mandate of the Affordable Care Act, or as a facilitator, if you will, because they need to attract employees, they need to retain. It becomes, providing good healthcare becomes a competitive advantage. But employers have not been, and still I don't think would consider themselves to be well positioned to provide this. The system is complex. Employers, Sam, you gave the example of drywall. They understand their industries, they understand their business very well. The issue of healthcare, financing healthcare, is not easily understood for most employers. It's also not easily understood for their employees. Our team spends an inordinate amount of time educating employees on how to access healthcare, how to access healthcare efficiently, affordably, and such. The issue of cost is certainly the biggest concern for employers. There is zero predictability in many cases for what cost will be, especially for small employers. We're a unique state in Oregon. We have more payers or insurance companies than many states. Inherently, that should create competition. However, I don't know that we've been able to see that. What we have is a more complex system. So I would just offer the perspective from employers that this is a burden. Some employers may have a more paternalistic sense and thus truly care about the health, the productivity of their employees and their families. That being the case, it hasn't created or hasn't made for an easy system for employers to navigate.
Great, thanks, Tracy. So do any of our panelists have any questions for Tracy?
I have a comment. So, we talk about sheetrock. I mean, I provide healthcare day in, day out, right? I'm a healthcare provider. I'm, part owner in the children's clinic, so I'm an employer, and it is unbelievably inscrutable trying to figure out, not only to make a decision for my family, but how do I talk to my employees about it? And now that I'm going to be a state legislator, I've just started delving into the public employee benefits and trying to decide, should I go with my clinic insurance? Should I go with my public employee? So it feels at times that it's deliberately opaque, and that and I think at the end of the day, it's wildly unpredictable to me about what it's gonna end up costing me. And we're really healthy. I think of me and my two sons, I think we've had 2 or 3 healthcare encounters in all of 2020, and so it hasn't cost us that much money. But it just I would say it's infuriating. Actually, it's pretty infuriating. That's all.
Yeah, I think that's an appropriate comment, and one of the instances that's resonated with me the most. A longtime colleague of mine, spent the first 64 years of his life incredibly healthy, and he spent it advocating for employers and employees. And then he was diagnosed with cancer, and quickly learned how difficult it is to navigate the system, how, like you said, Lisa, how infuriating it becomes to make decisions, and the cost.
Glenn
Right.
had his hand up. This is great. We're getting some discussion. Go ahead, Glenn.
Yeah, Tracy, I was just curious about your perspective about how employer attitudes towards sponsoring healthcare for their employees have changed over the last decade. I remember, maybe it was, I lose track of time, but 5-6 years ago, being part of an employer healthcare discussion. And I was surprised how much sort of investment and ownership in providing good healthcare benefits to their employers there was. I expected most of them would want out of that role, but I was surprised. A lot of them felt strongly it was something they really added value and was part of their culture and helped them attract employees. Has that changed? How do you think that balances across employers? Is it getting more difficult? What are your comments?
Yeah, that's a great question, and that attitude absolutely still exists, and I see employers on a variety of the spectrum. We see employers who providing quality healthcare is absolutely part of their culture. It's again that paternalistic attitude of we're here, and we believe part of our responsibility is to take care of our employees and their families. The part where I've seen a shift is in the difficulty in providing those and in making the best decisions as an employer from a cost perspective, but also on behalf of their employees and families. So the shift really is in the difficulty, not necessarily in the desire to provide. We expected, when the Affordable Care Act was rolled out and large employers had the ability to pay or play, so they could either provide affordable care for their employees or they could opt out and pay the penalty. We really expected to see more employers opt out because by and large, the cost of the penalty was far less than providing care. We didn't have a single client that opted out.
Thanks. We're going to, I think, come back to this issue because I have a few questions about it as well, but we're going to move along and have Glenn Rodriguez make some comments. Glenn.
Well, good morning, everyone. I'm really pleased to be able to have this conversation with the Pediatric Society members, really for two fundamental reasons. One, in my experience, pediatricians, you all are great system thinkers. You really get in being advocates for children that children only thrive when families are healthy and schools are healthy and communities are healthy. So you get the interconnections, and I really appreciate that. The second is some of the things I'm going to talk about at the last decade, sort of Oregon-focused work around primary care reform. Some of those efforts have centered around Medicare-sponsored reforms, and Medicare in its efforts have excluded children's health care often. So I think in some ways it's marginalized pediatric input to some of these discussions, though I will say in all the forums I'm going to mention, there's been great pediatric advocates at the table. But I think it's a really important discussion. I'm really, really interested in your feedback and comments. So my role is to talk about, to frame, Sam did a great job framing the big picture. But in my 40 years in healthcare reform, it's remarkable how little we've accomplished. And when I think back in 1978 as a passionate student about, I remember an issue of the Douglas magazine, feeling better and doing worse and talking about healthcare costs were unsustainable. It's just remarkable to me how good the American healthcare system has gotten at extracting money from the public. And it's I believe some of this chaos and complexity is simply cover for that ability to pull money into the system. So if we looked at it differently, how might we find some building blocks for reform, especially in this highly polarized environment where terms are alienating? So maybe a new term is a good thing. And my job is to talk about the idea of a quote unquote primary care trust. Or you might think of it as creation of a single payment system for primary care, sort of carving out primary care and think about setting up a system that could really support excellence in primary care, help us do our jobs better and get better primary care services for the public. So how might we approach that? This idea, I first became aware of it. Bruce probably's got much longer history than I do. In 2018, growing out of efforts in Vermont and Rhode Island, and some folks from those two states created a model legislation about how you might create what they call the primary care trust. In Vermont, it came from trying to build community-based systems of care, sort of like our CCOs. In Rhode Island, it came from the insurance commissioner enforcing that commercial payers had to pay an increasing percent of their premium to primary care and invest in primary care up to a certain target. So as we move those efforts to Oregon and think about Oregon, how might this apply here? How might we approach it here? And I would argue that because of the work of leaders like Dr. Goldberg, we actually have a pretty solid foundation for going down this path. So the first thing, if we're going to talk about a carved out system of support for primary care, we have to agree on what we're talking about the model of care is. What's the model for comprehensive primary care? And beginning with the major health reform bill, House Bill 2009 and 2009 that set up the Oregon Health Authority, one other thing it did was create the Oregon Patient-Centered Medical Home Program. And that program set up a set of standards describing what the model we were aspiring for back in 2010. And I had the privilege of participating in that first panel. And after we completed our work, Barbara Starfield, who died tragically the next year, came out to one of our family medicine meetings, and she commented that she thought the Oregon standards were the best description of primary care that she had seen. So I'm a big believer in that program and those standards. They've been updated multiple times. But I do think it gives us a strong foundation for what we're talking about for comprehensive models of primary care. And now over 75% of the clinics in the state are certified. That's over 650 clinics across the state. So, and in my experience on the ground level, it's driven some real changes. So I've seen fundamental changes like the integration of behavioral health, co-located behavioral health, like the expansion of team-based care, like the development of care coordinators within practices. So it's driven some real changes. The second Oregon-based foundation, I think, is the fact that we have public policy. So Senate Bill 235 in 2015, Senate Bill 934 in 2017, both set Oregon policy that primary care was important as a foundation of reform for the healthcare system, and that we needed to invest in the primary care system. And the 2015 bill set up the Oregon Primary Care Payment Reform Collaborative and a system whereby the Office of Division of, Consumer and Business Services, the insurance division, every year issues a report about how we're spending on primary care services in Oregon. I think that's been really important and valuable. 934 really said it is a goal to invest more in primary care and set a target by 2023 that 12% of premiums in the state would be invested in primary care systems. And I would argue that the work of the primary care payment reform has given us a head start towards, if we were going to develop a system to support primary care and a single payment system for primary care, what might that look like? What would be a system that would really support the work we do, pay for all the things we do, so we don't have to cross-subsidize from office visits to behavioral health or cross-subsidize office visits to our care coordinator and outreach. Everything we would do would be paid for. So what would a model like that look like? And the collaborative in their 2019 report proposes a model for this system. And if there's questions, we can talk about that. But I think it's a really strong starting point. The other thing that this would take is some kind of, so I called it a single payment system. Notice I didn't say single payer, because I believe a lot of the benefit can come if we get standardization and simplification of the payment. We can talk more about that. Even if multiple payers were contributing to the pool that funded that effort. You'd have to have a common sort of fiscal intermediary or shared utility to administer that system. But again, I think that's possible. And I think the development of our CCO system in the state, where the primary care spend report shows us now, Sam really based his comments on our fee-for-service system and unit-based payment. But when you look at total payment for primary care, this is across all primary care, and you can comment for pediatrics, because of fee-for-service payments, but in the Oregon Health Plan now, primary care, about 50% of their payments are flowing through non-fee-for-service based payments. And on a total average PMPM payment, Oregon Health Plan is a better payer than commercial payers. So the median expenditure across CCOs is about $49 per month. And for commercial payers, it's less than $40 a month. Kaiser's the big outlier in that, but if you take Kaiser out, commercial payers play substantially less into the total primary care pool than commercial payers. Now, there are tough design elements we have to work through. We'd have to clarify how a consumer could connect with the primary care, how panels are built, what combination of enrollment, assignment, attribution gets used. Risk adjustment's important, including social determinants of health. Benefit design is going to be important, as well as standardized quality and accountability measures. So there's a lot of work to do, but I think we have a really good start on it. Now, what are the potential benefits of a system like this? Well, I would argue for consumer, it's a system that's much easier to use. I can tell you, as now I'm a Medicare age citizen, unbelievable, the complexity about trying. We talk about our system provides choice. That's an illusion. It is impossible to make informed choices in this current system. And I can share personal stories to back that up. So for consumers, it could be an easier system to use. Depending on how we design it, it could really decrease out-of-pocket costs. And I think it has the potential really to improve outcomes in care as well. I wanted to emphasize what I think the potential benefits are for you all, for the primary care clinicians in the system. First of all, the payment system could be designed to support what we actually do. And the rise of telehealth has highlighted this challenge, but all kinds of contacts of patients are equally valuable, whether it's email or phone or video or in person. And we're stuck in this system of having to cross-subsidize from office visits to all the important things we knew that help our patients and patients' health. Now, not only that, but I believe it could also really decrease the administrative cost overhead in primary care practices. A study out of Duke a couple years ago showed that in the Duke system for a full-time primary care FTE, it was a rigorous cost accounting study. The direct billing cost per FTE was $100,000 per primary care FTE in direct billing costs. And that doesn't even count all the other impact you as clinicians feel from prior authorizations or referrals or all these other administrative tasks the system assigns to us. And so the other big opportunity, one of the big drivers of dissatisfaction for clinicians has been the development of our current electronic health record systems. Those are powerful systems, but they've done in a way that, as one of the leaders in family medicine said, turned clinicians into the most overpaid, least qualified data entry clerks in the nation. And so the time demands of the fee-for-service system have been enormous. And a time flow study out of the University of Wisconsin looking at how their primary care clinicians spent their time showed that of their 11.5-hour workday, over half of it was spent on EHR tasks. And about a third of those EHR tasks were directly related to some kind of billing, documentation, or coding task. So the cost of that is enormous. And if we could achieve a simplification in those systems and design our EHRs to respond to clinical needs, not billing needs, I think that's a huge opportunity. It'd give us a chance to allow innovation in primary care be about excellence in care, not excellence in billing and documentation. And finally, for the public payers, this is a chance to get predictable costs. This is where people like Dr. Goldberg and the work group saying to really control costs, we've got to get to predictable budgeted costs and budget-based allocation of resources to primary care. I would argue primary care is a good place to do that because the costs are more predictable. really intensive patients for us might be 3 or 4 times more expensive, but they're not 100 or 1,000 times more expensive. So our costs are more predictable. I think there's huge administrative savings possible in the primary care domain, and there's a potential to moderate overall costs. But I think the success of this should be determined by the quality of care we provide in primary care, not only how we affect the rest of the system, which has been the drivers of a lot of previous reforms. So I'd love to talk more about all this. It's not an easy path. There's a lot of details to be worked out. My final point would be, I think we as primary care clinicians need to be engaged in designing these systems. If you look at the ACA, the people early at the table were the pharmaceutical companies and the hospitals, and they were big winners. So I think we should be first at the table to design these kind of systems to make sure they support the work we do, the care we want our patients to achieve, and the health of our communities. So thank you.
Thanks, Glenn. That was great. Any thoughts from our panelists? Questions?
I will say as a pediatrician, and I agree with kind of the primary care medical home standards, but I will tell you, I cringe a little bit because what I picture is the screen and which boxes I have to check. And so I think your point about being sometimes a frustrated data inputter, I don't know the way around that, because I think, you have to show what you've done in the office, especially in terms of discussing the issues that are at the core of this kind of medical home. But I get a little cringy at that. But I understand the goal, but sometimes the day in, day out workflow is frustrating.
Well, and Lisa, my point would be that to a degree, I don't even think we appreciate those workflows are influenced by the fee-for-service payment systems. I would argue the EHRs are designed as billing systems, not clinical systems. And often the rigid rules are around what's needed for billing and creates a lot of the workflow challenges. And if we could break free of that, I mean, again, those changes have to ripple down. I think there's incredible opportunity there. I mean, I had an interaction with my primary care office yesterday where I had sent some requests for some services in via email. I got a call back from the medical assistants. I was on my exercise bike, so I actually timed the interaction. The tasks were easy to complete. They were scheduling a couple things. But before we got to that conversation, the MA spent over 3 minutes clarifying everything about my insurance status. And I'm a Medicare patient, so the change is less, but they had to ask all these things about me. They asked all these things about my wife, who's a consultant, and her health insurance. So 3 minutes added to the call just to verify insurance stuff in a situation where change was very unlikely, but those are the way the workflows were set up in that practice. So I just think there's a lot of implications there we don't even see, and a lot of added cost.
Glenn, how much did your heart rate go up during that conversation? Cycling?
I was on my exercise bike, Bruce, so I think my
Okay.
range up was limited.
We're not going to delve further into your personal medical history, but we're going to turn things over to Lisa for her comments. Lisa.
Great. I just have a few things to add. It's really great to be here, of course, because this is the Oregon Pediatric Society, but also I'm particularly honored to be on a panel with both Sam and Bruce, who I've called several times during my campaign. Sam was one of the first people I met with when I decided to run, and he's been an amazing mentor. So I'm a primary care provider, and so I know a lot about what you all are talking about. And I will say, being a pediatrician in Oregon has to be one of the best primary care jobs in the country, because we cover all kids here. So I both have jealous pediatric colleagues in other states, and I have jealous primary care colleagues in Oregon, where their patients aren't all covered. And also there is I call it a little bit of a dirty secret. In pediatrics, we have a higher percent of private insured patients. And so we are able to be in private practice, which I think is beyond is beyond the reach for most people who do primary care, who don't just take care of kids. We also have seen, and probably thanks to Bruce, we've also seen a nice rise in primary care reimbursement rates for our Medicaid patients. So again, pediatrician in Oregon, best primary care job in the country, and I really, really love it. And just as an aside, I decided to run for office because for years I felt like there's more I wanted to do for patients than what I could accomplish in the exam room. And I would say that's more about actual, social determinants of health and, upstream services, which is a whole other topic. But of course, I think of how we provide care to every kid in Oregon, regardless of their immigration status. And I think we need to do that for every Oregonian across the state. So I'll bring that perspective when those conversations come up in the legislature. As I mentioned, I'm continue to be frustrated by the inscrutable process of trying to choose healthcare, and it is, almost that in and of itself is enough to go for a universal payer. Although there's obviously a lot of other reasons, and we continue to see families suffer catastrophic financial events due to medical concerns. I remember about a decade ago talking to a family whose son had to have ablation for supraventricular tachycardia, which is, it sounds really, it's a serious cardiac procedure, but you're in and out in a few hours. And she told me like 2 years later that they ended up having to sell their home and downsize to pay the medical bills, and they had insurance. And I was very shocked, and in retrospect thought, I wish you would have called me. Maybe we could have done something different. It was something I hadn't even heard, knew about until a couple years after the fact. And then I guess I just want to comment a little bit on COVID. And I remember talking to Sam early in COVID that this, COVID is just a reminder how interlinked our health is with that of our neighbors. And if this isn't enough of a reason to realize every single person needs access to quality medical care, I don't know what is. And as Bruce mentioned, the pandemic has really unearthed the inequities in our system. I'm a Spanish-speaking pediatrician who practices in Washington County, and I'm certainly seeing the unequal distribution of COVID among my patients, and it's been more among the families, my Latinx families in Washington County. And the other thing I'm seeing, which, one of the reasons I got into running for office was concern for the achievement gap. And with the remote schooling, it's pretty heartbreaking to see the differences. The achievement gap, is really widening. And so we need to do something really soon on COVID to do what we can to get our kids back at school. I know that's a little bit off topic. And then seeing the rise of telehealth actually has been very rewarding. And then the mental health crisis, which was something that also got me into this race a year ago, has only gotten worse under COVID, especially for, maybe not especially, but certainly for kids who are feeling more and more isolated. So we have quite a bit of work ahead of us. That's all I really want to talk about in my comments. Happy to take questions, but look forward to the discussion to come.
Great. So this fantastic comments and presentations by all, and some really great questions coming in from the audience. So I'm going to start to hand those out. And the first one actually is one of the more important ones that I saw, that I just think warrants calling out in some discussion. I'm going to ask Lisa to comment on it, because Lisa, you just sort of spoke about some of the issues involved in this question. And the question is, how do we involve persons of color in this discussion? I noticed that this panel doesn't have anyone representing minority communities.
Yeah, and I have to admit, I'm not well versed in who is on the Universal Task Force. If that is being, if there are representatives of communities of color, but absolutely we need to have people from communities of color at the table, so that we really take into account how to best bring them into the system, or I should say better bring them into the system. We know the health disparities for people of color was a problem before COVID, and certainly is much worse now. So absolutely, I think having them help design the system would be really, really important. And I think, of course, we need to think about ways in our education system so that we can have more providers of color as well.
Great, thanks. And I would just add to that in terms of the Universal Healthcare Task Force. A key piece of that legislation was the establishment of a community advisory committee, which is very intentionally woven into the bill, but actually by the task force is really being woven explicitly into the work. So it is an important piece of it, not an add-on. And I think that that's been a way to gain a number of different perspectives. Okay. Here is there was a question in here about the amount of back office work that doctors' offices need to do, and how that would go away. There's several questions about that in a universal healthcare system, and I think the question is how would offices be streamlined under a universal system? And then I think as a corollary to that, what would happen to some of those jobs? And I think the same is true for jobs in insurance companies. We talk a lot about the fact that there's so much administrative burden. You know, Glenn almost had a heart attack on his bicycle because of administrative burden. But those are also people doing jobs, whether they're beneficial or not is a different story. But I would be interested in panelists' thoughts about one, that workforce, how much of that shouldn't go away? What do you do? I know that's an issue that keeps coming up. Glenn, you had your hand up.
Yeah, so a couple comments I would make there. One, again, the journey to purposely design a payment system to support the primary care model we want to deliver gives us a lens to look at the way we work and redesign our practices as well. There was an evaluation in, I believe, 2014, 2015 by Portland State looking at the Oregon Patient-Centered Primary Care Home model of care and program. And it did a number of things, but one of the things that it did, it looked like it sort of made estimates about what would the cost be to transition a practice to this more team-based comprehensive care model. In order of magnitude, the number they came up with was $100,000 per FTE, which you'll notice is just what we're spending now on direct billing costs in primary care practices. So that Duke cost accounting study was looking at assigning, personnel in the office, direct dedicated billing clerks, et cetera, but time we all spend. So the MA time, the doctor time, et cetera, all in preparing bills. So it's a redesign challenge. It's not business as usual for sure, but it's saying, there is the opportunity to redeploy our current staff in new ways to provide the care we want to provide rather than being a slave to a fee-for-service billing system. So I would just argue that I think there's a huge opportunity there to redesign our work and redeploy our staff. And it's sort of the same order of magnitude cost.
Sam, I think you wanted to respond as well.
Yes, building on what Glenn said, there are numbers out there. There are several dozen single payer studies in individual states and nationally that have estimated the number of billers who would be, and insurance agents who would be out of work with a universal care system. In Oregon, anywhere from 8,000 to 12,000 people, which is a lot of people. On the other hand, some of the studies went ahead and estimated how many new jobs would be created when we have tens of thousands of people without insurance who now are seeking primary care. There will be new jobs created. The estimate in those studies that looked at it said that for every job loss in billing, there'd be 1.5 to 3 times as many jobs created in hospitals, clinics, ancillary, work in healthcare, X-ray technicians, etc. Almost every universal care plan, statewide universal care plan, and U.S. healthcare plan provides for retraining. This means if I'm a hospital biller and now I've lost my job, one, there's money so that I can retrain. Overnight, I'm not going to become an IV technician, but I can retrain. Second, I'm now in a job market in which the number of vacancies is 1.5 to 3 times the number of applicants. And most importantly, while I look for a job, I and my family have access to healthcare. When we are reorganizing a $4 trillion industry in the United States, that's about as soft a landing as we can create.
So I want to bring Tracy into the discussion. Couple of questions I'm going to ask you to comment on, but actually everyone else as well. One question for Tracy was, do you get a sense from business owners that they would rather not have the cost and hassle of providing healthcare? I think that was a tag on to Glenn's comments. And then let me first start with that one. Then there's another one.
Yeah, that's a great question. I think that, as I mentioned earlier, certainly the lack of predictability about the cost has been problematic for employers. But the second piece would be value. And Dr. Reynolds, you alluded to it. Employers struggle with balancing the cost constraints with the value that they are providing to their employees. So an employer feels an incredible burden to provide coverage that's not going to bankrupt their employees and their family. Again, I believe that there's still a very paternalistic, there's a competitive advantage to providing quality benefits, and employers know that they are in a position, I think employers for the most part that we work with accept this responsibility. However, the larger concern, I believe, becomes value. For the cost that they are paying, I think employers are struggling to feel the value of that.
So there was a question along with that I would throw out to the panel, which is something that I've always been curious about, that, employers and businesses have, often complained a lot about the rising costs of healthcare, and it really affects their bottom line. But there's seemingly been, and not from everybody, but for many, a reluctance of employers to sort of get involved in some of the health reform debates, to be supportive of universal health care, which could potentially lower costs. Any thoughts on, from panelists, reasons about that? And there was a question in here asking about if anyone knew of any surveys of employers' attitudes about universal health care. Sam.
Some 10-year-old data is that an employer in Oregon that buys health insurance for their employees spends about 12% of their payroll on premiums. But answering a question in the Q&A, they spend on average a 2% additional on extra HR people to handle these healthcare benefits. Replacing that cost with a flat, say 12% payroll tax that does not go up and down, that's independent of the number of employees that you have, that's the same policy that your employee had when they were uninsured or when they were employed by somebody else, eases this transition. And Tracy mentioned the taking care of employees. It would be very likely that employers who have this create a family situation could provide benefits, say like a robust pension fund, like child care, like educational forgiveness, like carpooling, transportation credits. There are many ways that employers can attract good employees with families independent of healthcare. And of course, employers can still provide supplementary and complementary healthcare that would improve the benefits even more than the standard. My guess, note the word guess, is that a majority, though not all, of Oregon's employers would seriously consider a universal health care plan as the more cost-effective and stable alternative to employer-sponsored health care.
I think just a couple of comments on that. First, I think the reluctance on the part of employers, as I see it, is really a lack of knowledge. Employers are not in a position to understand what that would look like. Second, I couldn't agree more with you, Sam. Employers are looking at their finite resources in determining whether they spread those resources to retirement benefits, to health benefits, and that pie, if you will, just becomes more and more stretched. It would, Sam, you referenced 10-year-old statistics. I would be really interested to see those statistics today, because the inflationary rate of healthcare has really ballooned costs in that area for employers. So I would suspect that those percentages are much higher today.
Yeah, and I would just add, as an employer at the Children's Clinic, I think you're right. It's almost like, well, this is the devil we know right now, right? Just the unknown is feels a little scary, and what it means for our employees. But boy, the way we've eroded, we've all had to erode our benefits over the years for higher out-of-pocket expenses for our employees it's difficult. It's hard. It doesn't feel good. But with the 73% rise in premiums in the past, I think 10 to 15 years, it's something has to give. And obviously, when you talk about the pie, it's wages and benefits. So something you have to, there's only so much you can slice up that pie. So thank you.
So there's a question here, and for anyone that wants to handle it, it seems so much of what drives up costs and inefficiencies is the fact that so much of reimbursement is fee-for-service based. Is there an alternative? Does anyone see an alternative to doing away with a fee-for-service model if we are to achieve the goals that have been mentioned about universal health care?
I can try to catch the football here, and maybe one of the panelists can pick it up when I
I'm
fumble.
going to let you do that. And I saw Glenn flinch, so
Thank you.
He went to raise his hand. He's going to be next.
There are three ways to pay physicians: fee-for-service, capitated funds, and salaried. And they're all bad. And they're all used around the world. And some countries make one of these formats work. Other countries make another format work. They all lend themselves to physician gaming of the program. What we know from looking at other countries is there's no physician payment program that causes a dramatic reduction in cost without causing a dramatic reduction in quality. When we're talking about universal care, when we're talking about single payer versus multi-payer, we're talking about revising the financing system, not revising the delivery system. When we ask what provider is paid how much for what patient, under what conditions, for what treatment, that's a delivery question. We know that without touching the delivery system, universal care financing allows better care to more people for less money. Once we've crossed that river, then we can hack and claw our way through the jungle of physician reimbursement, but one mountain at a time.
Glenn?
Well, I would argue, that's, so this question frames part of the reason I'm very interested in the primary care trust approach, or single payment model for primary care approach. Because to Sam's point, I tried to make the point that I believe we could actually build a financing system on the model of care we've already started to implement and said we want to have. So it's not financing divorced from the delivery system. It's a financing system designed to support a model of care we say we desire and want. And I agree with Sam that there's no perfect payment model, but I would argue for primary care in particular, the fee-for-service model is incredibly broken and burdensome. And I think we in primary care have been asked to try to deal with the fragmentation and chaos caused by the fee-for-service system. We've been asked to carry even more burdens to try to make the other parts of the system work. By our very nature, our commitment to coordination, et cetera. So my argument is that the impact of the fee-for-service system is especially onerous and harmful in the primary care domain. And an alternative payment model, and a model like recommended by the Oregon Primary Care Payment Reform Collaborative, is basically a combination of all the things Sam mentioned. It would be predominantly a risk-adjusted capitation model supplemented with fee-for-service for certain services that are special, and then supported by some kind of quality incentive payment. That's the basic outline. And again, that's not perfect. It could be gamed, all the same problems. But if we align it with the model of care we want, I think we really have a chance to both make the care easier to access and better for our patients. They don't have to spend 3 minutes every phone call answering questions about insurance. Their access to primary care is not limited by insurance networks, et cetera. And I would argue that our practice lives in primary care could be vastly improved if we're spending more of our time and energy caring for patients and less being a slave to the fee-for-service system. So my argument is, if we can design a system to support the model of care we want, we can find a balancing point in the middle that could allow us to make some real progress. And I think primary care is the right place to start again, because we can provide predictable and value. So for order of magnitude, 50, 60 bucks PMPM, we can provide good comprehensive care. In the world of healthcare, that's a pretty damn good deal.
And, you know, Glenn, I think you touched on what was another question in here, which I'll just tag onto that, which was, I'd like to know more about how we can use universal healthcare to eliminate clerical work related to documentation. I'd like to be paid for caring for patients and be able to document information that's relevant to me and other providers without worrying about what the insurance company wants to see for reimbursement. How can we create this kind of a system?
And I think we can all acknowledge that the cut and paste multiplication of notes, often with information that's inaccurate or redundant, to meet billing criteria has been one of the worst things about the EHR implementation. You know, that it's created, often you'll get specialist notes that are pages long, and the only relevant part is their assessment paragraph at the end, and much of the other data is frankly wrong. And it's all driven by this, you know, put things in your notes so you can get paid at a higher rate kind of stuff. So that's one example, but if we can reimagine the world and work our way through this, I think there is huge administrative cost reduction and simplification opportunities. But I continue to argue for primary care, we need a single payment approach, because I don't think we can do this if we have 13 different payers doing it 13 different ways. One other argument I would make, I think there's potentially something in this for the payers too. Primary care is expensive for them, lots of small bills. And so if they could contract with a single fiscal intermediary that paid for primary care, I would argue there might be savings for the insurers as well.
So I'm going to switch directions and ask a political question that came in, which I think is really interesting. What is the political strategy to counter the moneyed interests in maintaining the status quo? Drug companies, the insurance industry, and others will likely push back against any true reform. Glenn mentioned how efficient our healthcare system is at extracting money What's the political strategy to counter that?
I'll walk in where angels fear to tread. An oversimplified political approach is to use one of these devices. This is a weapon of mass destruction. Imagine if every person who is listening to this seminar writes a 3-sentence letter to their state representative, hello Lisa, our state senator, and our US representative and our 2 US senators. The first sentence, dear elected representative, first, our healthcare system has failed me, failed my patients, failed my family, failed my community, failed my business. Fill in the blank. 2, I want a universal healthcare plan that guarantees my family will have access to healthcare no matter what happens to me. 3, I want you to make it happen. Sincerely, your voting constituent. And you sign it. P.S. Have your scheduler arrange coffee so you can tell me what you're going to do about this. Now imagine an elected representative gets a letter like this one day, and the day after that, and after that, and the week after that, and the week after that, and the week after that. Eventually, when the campaign contributor sets a bag of money on the legislators or the congressperson's desk and says, I'd like you to stamp out universal care, your elected representative will swallow hard and say, I don't think there's enough money there to convince all of my constituents that everything is just hunky-dory with our healthcare plan. So I'd be happy to take your money, but I'm going to need to take care of my constituents and vote for universal care. And then, of course, if you don't get an answer to your email or letter, don't be shy about writing that letter again and again. That is how we as users and providers of healthcare can change our healthcare system in the face of the largest industry in the world that's deeply invested in keeping things just the way that they are.
So Lisa, how do you feel getting letters like that? Come on.
Well, Sam is a future constituent, so I'm envisioning a daily letter. No, you know, I obviously that's an important point, and the money stuff is pretty disturbing. Having been a candidate now who ran a campaign, 2 campaigns, one in the primary, one in the general. You know, one thing that I've talked about is that the people with money are the people who have or the people who spend money on campaigns are the people who have financial interest in the outcome. And I know this is probably not profound, but it's pretty striking to me. Like nothing against the American Academy of Pediatrics, but they have no, you know, they have no PAC. So when a pediatrician's running for office, you don't get any money from the American Academy of Pediatrics, but, you know, Pfizer has a PAC, you know, for example. So just, you know, just so the moneyed interest in politics is very lopsided. But I also think it's a little deeper than that. I think there is a public skepticism around socialized medicine. We know that the moneyed interests have, I think, you know, kind of dominated the narrative on this. So I do believe we have a lot of work to do, whether it's as physicians or politicians, in talking to the public about what this will mean for them. So I think that's part of it too. I'm not sure a lot of people right now are, you know, the average Joe is clamoring for single payer healthcare. I mean, there's a lot of advocates, of course, but I think we probably need to do a better job in educating the public, you know, and the whole thing of people saying they like the Affordable Care Act, but they don't like Obamacare. I mean, we do need to do a better job at educating the public about what this means. And then they in turn will pressure the politicians.
Great, thanks. Glenn.
So I'm the last person to give any helpful advice about political strategies, but I'll make a couple observations, and this is probably the unrealistic optimist in me, and I can't say in my 40 years on this work that this unrealistic optimism has actually been rewarded in many situations, but elements of the story I talked about have gotten, even in this polarized political world, broad consensus and support. So for instance, Senate Bill 934 passed in 2017 was passed unanimously by the Oregon Senate. And that bill called out the need to invest in primary care as a foundation for the healthcare system. And I'm not probably the right person to talk about the politics of why that happened, but I thought that was remarkable. And similarly, the work of the Oregon Primary Care Payment Reform Collaborative in the model they proposed in 2019, that 40+ stakeholder group, including many commercial and payers and CCOs, that report was supported unanimously by that collaborative work group. So I guess what I'm trying to say is there's some ideas in this that may be able to achieve some degree of consensus even in this fragmented world. And I'm not sure how you put those political pieces together, but it feels like an opportunity.
So there are a couple of questions in here, which I'm going to ask both Glenn and Sam to respond to. They were, really directed at the primary care proposal that Glenn was putting on the table, and specifically, Glenn, whether what you were proposing is an alternative to moving to single payer or part of a comprehensive reform. And so I'd ask you to respond to that. And then Sam, I'd be interested in your thoughts about, along with that, is the notion of the risks or benefits of stepwide approaches versus moving in one fell swoop to universal care. So let's start with Glenn.
Yeah, so the way I think about this personally, at least, is that this kind of reform in primary care could be a workable first step in the movement towards more comprehensive reform. I wouldn't argue it's the whole solution or the last step, but I believe it's an achievable first step that could have a big impact. And if successful, could demonstrate some opportunities. I'm frustrated that the reverse has happened, that meaningful reform in primary care has often been halted by challenges. Well, what are you going to do about the rising costs of prescription drugs? There's not money to do this for primary care if you don't control the drug costs. And I'm trying to turn that argument on its head. Let's say, well, let's start with a part of the system where we have an idea about what we want to achieve in the model of care, an idea of how to finance it and do it. Let's start there, make that work, and then work our way through the rest of the system. That's an incremental approach in our highly polarized environment. It feels like an accessible first step. I'm sure others will argue it's, may not be the best route.
Sam, some thoughts?
Thank you. I think Glenn made a very good case for the primary care trust. Incrementalism has two different ways to approach universal health care. One is terrible, one is better. The terrible way is to create more risk pools with more patients, to fractionate our patients into smaller and smaller risk pools, each one with different costs, different insurers, different benefits, different networks. That's bad. However, we can approach universal healthcare with incremental systemic changes. One is, like Glenn mentioned, we're going to bring primary care into a single payment so everyone has access, no matter where they are, to primary care, and every primary care physician is going to get paid no matter who their physician is. Other incremental steps are having a single pharmacy purchase manager for the whole state of Oregon. Whether we have single payer or universal care or not, that's going to save us money. Having a single electronic medical record, so no matter which provider you go to, your records are available. Having a single set of benefits that every healthcare policy has to cover. These are all incremental steps that I believe are good for Oregon and do in fact bring us closer to universal care and provide value in their own right, even if we do nothing else.
I sit from admittedly a limited perspective, but primary care is something that we've encouraged our employers that we work with and their employees to utilize for many, many years. Earlier, I discussed a complex system, and we believe that individuals working through their primary care relationships make good sense. The concern, and this is where I say I sit from admittedly a limited perspective, is the lack of primary care accessibility. So maybe a comment, but also a question to the panel: how do we address that? And is that the issue that it's made to be?
Thoughts?
Yeah.
Let's go to Sam and then Glenn.
Okay, I'm going to hit that one head on by first addressing another important concept in our Q&A. Racism is woven into the fabric of American healthcare because it's woven into the fabric of American society. Single payer will not change that. Single payer does give us universal healthcare, even if it's not single payer, does give us the opportunity to correct some of the racial and geographic imbalance. We can pay providers more across the state to provide underutilized services like primary care and in underserved areas like North Portland or immigrant communities or rural and small towns or Native American reservations. That's a tool that universal care provides us that we do not have right now.
Glenn, you wanted to say something.
Well, Tracy, I would hypothesize, and I'd appreciate your challenging this. When we say lack of access, I think consumers and employers are basically saying healthcare is hard to use. It's hard to get into, it's hard to get what you need out of it. I actually think we have the infrastructure to provide the primary care that's needed in this state. I don't think we're that far away on workforce and infrastructure, but we got to do it differently. And when you have a payment system, I'm a broken record here, but I think the financing and payment system has been a huge barrier to meaningful reform. When you drive all the work through office visits, when you don't pay for phone calls and email, those things don't get done. And what consumers want is easy solutions to their problems. And if that's an email or if that's a phone call or if that's a video, that's what they want. And so part of it is performance. For primary care, it's performance. It's stepping up and making it easy to use our systems and meeting our patients' needs. And if we did that and we were paid to do that, my hypothesis is you could see a rapid transformation. And we actually, I think even across the rural parts of the state, we have pretty solid infrastructure. We have some of our most creative practices out in rural Oregon. So I think this is doable.
I appreciate that perspective, and two things resonated with me. First, COVID has brought to light the ability that we have to create access to care in different ways, and it's pushed innovation in our industry forward at a pace that, maybe faster than any of us were ready for it, but it's here, and we need to adopt it. So, one, I appreciate that perspective, and I think you're absolutely spot on with that. Two, I think it highlights the whole issue of what we're talking about today, and that is education. And so educating, we've discussed that the system is hard to use, but educating folks on how to do it, educating them on what a single payer system might look like. And it really comes down to that across all systems.
So We are about at the end of our session. It's been fantastic. Really great dialogue, great ideas, and that's really because we've had such a fantastic panel. I'm going to give everybody the opportunity to close out with just a sentence or two. If there's anything that we didn't talk about that you think bears mentioning, or something that you want to emphasize in a sentence or two, I'd like to give you that opportunity. And gonna start with Tracy. Any final thoughts?
Yeah, thank you. First, thank you for allowing me to be a part of this. I'm encouraged by this dialogue. I'm encouraged because of the passion and commitment to these issues. And my final thought would be, we've got to bring all interested parties together in these discussions, not just those with the most financial at stake.
Great. Glenn?
Well, I would hope that if folks are interested in these ideas and themes, they would do what Sam suggested and engage in the political dialogue and process. Representative Prusak is leading a work group out of the House Health Committee called the Universal Access to Primary Care Work Group. That group just finished its work, and many of the ideas I've been advocating here today are in that report, and that will be going to the House Health Committee in December. So hopefully some of these ideas will get in the political debate and dialogue. And so I reach out to Dr. Reynolds as well about that. But I would hope in the near term that we're actively pursuing some of these ideas.
Sam?
Thank you, Bruce. Both Tracy and Lisa brought up the concept of education. That's probably the place where we can make a difference. We can talk about universal health care as a benefit to our families financially, to our businesses financially, to our communities financially. The temptation is to approach it like me as a moral crusade. Nothing alienates people more than a moral crusade. There are some very real values to businesses, to families, to communities. It's time for us to outreach not just to our elected legislators, but to everyone in our community. You can get a hold of any one of us, the panelists, through the Oregon Pediatric Society. We are welcome to talk more about this to any group you put together. So thank you very much for the opportunity to participate in this panel.
And then going to give the final comment to Lisa, but before doing that, soon to be Representative Reynolds, just on behalf of everyone, we're really glad that you'll be in the legislature and representing a lot of these issues. And it was a lot of hard work getting there. And we all appreciate the fact that you will be there to represent the voice of a lot of what was in the discussion today. So with that, some final comments.
Thank you. Thank you, everyone. Thanks, Oregon Pediatric Society. What a great panel. And I know, I'll be honest, Bruce and Glenn and Sam have been doing this work long before I got involved, and I am still getting up to speed on actual healthcare policy. But I do really think there is a strong appetite in the legislature to do things differently. And this predates my being elected a couple weeks ago. Obviously, Andrea Salinas, who's the chair of the House Health Committee, is quite a champion about these issues and is putting forward a public option for people to try to prevent some of these catastrophic health expenses for Oregonians. Maxine Dexter is another physician who's currently in the legislature and was elected a couple weeks ago as well. We have Elizabeth Steiner Hayward, obviously the unbelievable Rachel Prusak. So I do think that there is a critical mass of people who want to break or form that iron triangle. I'm not sure what the metaphor is, but certainly, better health for more people at lower cost. And obviously the people on this panel will be, it's very important to be creating and implementing that. So thank you so much.
Thanks, Lisa. Thanks to everybody from the Oregon Pediatric Society for putting on this forum. You can see there at the end, stay in touch. There's websites, Twitters, emails, etc. Thanks to the staff for a great event. And most importantly, please remember, wear a mask, wash your hands, stay socially distant. These are important things. Stay healthy and be careful out there. Take care.